This presentation is adapted from Sleep Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Dr. Peter Sloan, and I'd like to introduce Dr. Brian Bonner.
So last but not least, positive airway pressure therapy, or PAP therapy. This is the treatment of choice for severe OSA. It's the most effective treatment for mild to moderate OSA, and it does have favorable outcomes. Widely studied, the treatment of positive airway pressure reduces symptoms and improves several endpoints of comorbidities such as hypertension in CHF. It improves functional class as well as ejection fraction, and there is data that shows improvement in the hemoglobin A1C. OSA treated with PAP therapy, survival improves if patient has moderate to severe OSA. And the positive airway device is one where we're actually delivering air pressure therapy through a nasal interface. Several advantages over using the nasal interface over the oronasal interface that also covers the mouth. And so the nasal interface will be delivering lower pressures, will have less leakage, and higher success in achieving airway patency. Note that the airway pressure here is the flow is directed into the nasal airway, which will be delivering air posterior to the palate and posterior to the tongue, so that, at least in the supine patient here, that the structures are being pushed upward, whereas there can be the delivery of air pushing down on the tongue with air pressure delivered through the mouth. So the AASM recommends in the recent PAP position that the nasal interface should be the first type presented and encouraged to the new PAP patient. So in most practices, 20 to 30% of patients will who are on PAP therapy will actually choose an oronasal interface. This is sometimes referred to as a full face mask. And this is usually chosen by patients who have very poor nasal patency, deviated septum, different problems with polyps or congestion, so they can't breathe well through the nose and really have little choice. Unfortunately, these devices will be requiring a higher pressure than if the patient had been using a nasal mask, perhaps 2 centimeters of water pressure. And so this contributes to potential for problems like leakage. And the mask has a larger perimeter, so there's more places the leakage can occur. So moving around, positional leakage can be a problem, and so this should not be the first pick. Now, I think that many of us see patients who come in who are on one of these and ask why they're using a full face or an oronasal. They'll say, well, the therapist told me to use the full face because I'm a mouth breather. So the answer should be that everyone who has an obstructive apnea, who has the obstruction of the airway behind the tongue and the palate, will all be a mouth breather. And so if you can't breathe through your nose, you will open the mouth and make that effort. So the fact that one is a mouth breather should not be what dictates that they should be on a full face mask. In fact, all of us being mouth breathers that have OSA, the idea is to unlearn being a mouth breather by properly being presented a nasal interface, acclimating to it, and then developing confidence that one can breathe nasally without having to work hard or open the mouth. So most of us should be making the effort to represent this to all of our full face mask patients periodically, the advantages of the nasal interface. So PAP treatment is certainly a very common reason for a patient to be following up with us. And the initiation of the CPAP is generally one that, at least historically, was one where we tried to evaluate the therapeutic pressure. That is the pressure that on the titration study in the sleep lab is able to eliminate apneas in all scenarios, on the back, in REM sleep, etc. And so generally the pressure is determined in that fashion. And there certainly are some advantages to having a study in lab. It allows us to be sure that the mask is not leaking, that the pressure eliminates all apneas and doesn't cause a paradoxical problem where they develop central apneas, a condition known as complex apnea that we'll review in a future session. And also to be sure that that oxygen desaturations are eliminated, that the patient doesn't also need a higher pressure or needs supplemental oxygen. So with the advent of auto PAP or automatic CPAP therapy, one can set a range and then the patient can be without a titration set out on this range. And so many of the advantages of the titration then are skipped, and so it requires very close follow-up because APAP doesn't always eliminate desaturation, doesn't preclude the chance of developing central apnea, and doesn't show that leakage until you see them back in 6 weeks is a problem. So we typically need to follow these patients closely. We can set the range at the universal range of 5 to 20, or if the patient was titrated in the lab, we can bracket around that pressure and start a little lower and allow it to go up a little higher if the machine needs to. BPAP or bilevel positive airway pressure therapy. Many people like to call it BiPAP, but actually that's a proprietary term by by a specific manufacturer. So I'll try to refer to this as bilevel PAP therapy. Can be used if the patient has pressure intolerance on CPAP or APAP. So just having pressure directly blown into an interface as opposed to allowing significant reduction in the expiratory pressure can be an advantage. PAP treatment needs to be set up with a carefully chosen and trialed interface or mask. And so this does not get satisfied if a patient who had a home study, the next step is that they're sent a box in the mail with a random mask in it. And I will tell you that this continues to happen. And I know that there are cost challenges, but when that patient brings in some of these masks that don't fit or the wrong style, it is basically a setup for the patient being non-compliant on this therapy. So there's many different types of interfaces. There's the need to have the size fit, and so the patient who's initially set up ideally should have a therapist spend some time making the selection and making sure it fits well, and then ideally to have them wear it in the center just for some time to be sure they're comfortable with the pressure they're going to be being delivered through that interface. So continuous positive airway pressure delivered as a fixed pressure is the traditional treatment for PAP therapy. And this does require a titration to establish the pressure that's able to eliminate apneas in REM as well as in supine position. It's interesting that there are some algorithms that are presented when a patient is sent to us from a home study company that says that there's an algorithm that guesses at a CPAP pressure. And I will tell you that looking at these algorithms that the pressures that are suggested are often wrong. And so please do not rely on this. There's many things that go into identifying a pressure requirement, the patient's anatomy, and position they sleep in. And so this pressure can be determined by a machine, an automatic machine, but when CPAP pressure is measured in the lab, it is to specifically identify the pressure that gets rid of the worst case scenarios, such as the back and in REM. You'll notice here that the CPAP pressure here, let's say it's at a pressure of 10 centimeter throughout that period of usage. That pressure may be a bit high for the patient to fall asleep, so there will be a ramp feature in the first 20 minutes here where you can see that the patient may start at a pressure maybe of 5, and then the machine will go up to that therapeutic pressure. Auto CPAP or APAP is provided by the two major PAP manufacturers, Philips Respironics and ResMed, and are, I think, very good alternatives to CPAP. In fact, I don't even order straight CPAP machines anymore because if the patient really wants to be on CPAP, you can set their APAP machine at a fixed pressure level. So this will sometimes in the community actually replace the need to have a titration study, which I do have some concerns about because of reasons previously noted. There are several things in a titration that will not be noted if you put the patient on APAP, so they need to be followed closely. So you'll notice in the red line here that the mean pressure will be lower than CPAP because there are times the patient may not need that pressure of, say, 10 centimeters. When they're on their side, when they're not in REM sleep, that pressure will be lower, and the machine is basically tasked to maintain an open airway. And so those machines will be delivering pressure, and if that pressure is not necessary, it's constantly reevaluating whether a lower pressure will accomplish the same thing. And so it is I think also important for patients who may have changes in their weight that pressure of CPAP may not always be effective. And so if set at a high range above that, it will allow the machine to deliver higher pressures if needed. So auto CPAP or APAP, I think because of the very incrementally minimal amount in terms of cost over CPAP is what I would recommend in patients who start on PAP therapy if otherwise you were thinking of just plain old garden variety CPAP. So now in the next step, as far as a patient who may have problems tolerating PAP therapy in terms of pressure intolerance, there is the option of using a bilevel positive airway pressure device that will allow for a reduction in expiratory pressure that many patients find to be much more comfortable enough that it takes them from an intolerable situation with plain old CPAP to one that's actually very comfortable. The option then would be an automatic BiPAP unit or titrating the patient in the lab and finding a fixed pressure BiPAP. But BiPAP is going to comprise of a higher pressure that's delivered during inspiration and the lower pressure that can be set specifically at, say, 4 centimeters of water lower or a different value than 4. But typically 4 is a nice reduction that gives the patient relief when they're exhaling. And at the beginning of the therapeutic period, there can also be a ramp for that until it gets up to that pressure. This actually is a comfort feature that is at some cost. And so to go to a bilevel positive airway pressure machine, we're generally talking about something that's twice as costly. And so whether it's the patient's cost or the insurance cost, one option is to just utilize the expiratory features that are already on the original PAP machine. And in the Philips Respironics, it's a C-Flex feature, and in the ResMed, it's called EPR, or expiratory pressure reduction. And so you can actually set those features at, say, a setting of 2 or 3 to reduce pressure with exhalation, and this may be enough to not have to go to a formal auto bilevel device. So this is the end of part A. I want to thank you for your attention in this section on therapy. And in part B, we're going to be reviewing how we apply these therapies and follow them for our patients.
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.